I'm a medical oncologist and I treat melanoma and skin cancers and kidney cancer, probably 50-50 overall. The answer to that is none outside a clinical trial, because neoadjuvant treatment hasn't in fact, been established yet in kidney cancer. And I guess I treat melanoma, and so for me, that's one of the really interesting questions, that obviously neoadjuvant treatment with checkpoint inhibitors has become an established standard of care in melanoma in the last 3 years. And in kidney cancer, there have been attempts really for over a decade to establish neoadjuvant treatment, and to date we don't have any data that's changed practice, so it's a gap in kidney cancer, I would say. One of the issues in kidney cancer is there are quite a few small non-randomized trials which demonstrate feasibility, they demonstrate safety, but of course what you really need is randomized trials to change practice. And so far there's only been one randomized neoadjuvant checkpoint inhibitor trial, which is called PROSPER, which is a US cooperative group study, reported I think at ESMO 3 years ago and now published. And in a nutshell, what they did was to give nivolumab prior to surgery, a month before surgery, and then they compared that with the standard of care, which would be to have surgery and then a year of checkpoint inhibitor. And in fact, the only approved adjuvant checkpoint inhibitor in kidney cancer is pembrolizumab. So there's a bit of a story there as well, because actually there's been a trial of nivolumab and ipi/nivo in adjuvant renal cancer, which was negative, checkmate 914, for reasons I certainly don't understand. I don't think anyone really understands. And I guess for the record, and it's important, in kidney cancer, there was also a negative adjuvant trial of atezolizumab. So as things stand at the moment in adjuvant, which is, I think, in many ways the place you start before you start thinking about neoadjuvant, we've got one positive trial and two negative trials. And so in some senses, I think in the field, that may have caused a little bit of confusion about the potential benefit of adjuvant checkpoint inhibitor therapy. So 75% of kidney cancer is clear cell kidney cancer. That refers to the appearance under the microscope. And then the other 25% is actually a number of different diseases. So they're all clumped together under the heading that people historically have called them non-clear cell kidney cancer, now sometimes a rare variant kidney cancer. But papillary is probably the next commonest one, 10 or 15%, then chromophobe maybe about 5%, and then even beyond that, there's probably another 5 or 6 subtypes. So to answer the question, most of the evidence that we have really for any drug therapy in kidney cancer is in clear cell kidney cancer, and certainly the adjuvant pembrolizumab trial, Keynote 564, only included clear cell kidney cancer. So if I was looking for a signal here, it would be in clear cell kidney cancer, because the other subtypes of kidney cancer actually are biologically, I would say, distinct diseases that happen to start in the kidney. So a treatment would need to really be individualized depending on the histological subtype. Well, no, so that's an excellent question as well. So we've had anti-VEGF therapy in kidney cancer for 20 years now. And then checkpoint inhibitors have come along really in the last 10 years or so. But with anti-VEGF treatment, there were several adjuvant trials that have been done in the past which are basically negative, with one exception, S-track. So adjuvant anti-VEGF therapy really never found a place in kidney cancer. But I suppose the question then is, if we're thinking about neoadjuvant treatment in kidney cancer, would you just go for a checkpoint inhibitor or a checkpoint inhibitor combination? Ipi/nivo would be the obvious one, because there's an approval in advanced kidney cancer. Or might you go for a checkpoint inhibitor plus an anti-VEGF treatment? And I think in clinical trials, both of those approaches are being looked at the moment. There are a few logistical issues there. And one of the points I like to make, if we're comparing stage 3 melanoma, lymph node involvement, with adjuvant kidney cancer, is that the surgery for nephrectomy for kidney cancer is actually a very different type of operation from doing a lymphadenectomy. So then that brings the issues of safety and wound healing and all sorts of other things in. And my personal opinion is, although anti-VEGF treatments may have a role, there are actually a few issues with thinking about them in the neoadjuvant space because of things like wound healing. The answer is possibly yes, but if we think about checkpoint inhibitors in kidney cancer, the level of activity is actually less than in melanoma. And again, to make the same analogy, if you're talking about surgery for stage 3 melanoma, you're usually talking about relatively small macroscopic disease burden. If you're talking about kidney cancer, at least high-risk adjuvant kidney cancer, some of these tumours are going to be more than 10 centimetres in diameter. So putting that together with the fact that the drugs have got less activity, and from the data we have already, the pathological response rates are way lower than in melanoma, I'm not really sure that you're, at least in the foreseeable future, going to see significant tumour downstaging, at least in general, to facilitate surgery. So for me, neoadjuvant in kidney cancer would be more about identifying a priori high-risk groups of patients where actually the neoadjuvant approach is better than the adjuvant approach. And again, to put melanoma and kidney together, with kidney cancer, not every patient who's got a primary kidney cancer is necessarily going to have lymph node involvement. So I've said this before, so if you were to compare melanoma with kidney cancer, it could even be apples and pears, unless you select the patients well for this type of approach in kidney cancer. Don't think so, at least not at the moment with currently available techniques. And some of that I think is going to get back to the issue that if you, and obviously I'm not a radiation oncologist, but if you're talking about the amount of dose of radiotherapy that you can effectively deliver to a tumour, these kinds of very large tumours, I think a lot of the time it's going to be difficult to get an effective dose in. And then my surgical colleagues will say, well, if someone's had radiotherapy for whatever reason, then the surgery can be even more difficult than it was in the first place, although I accept your point about sarcoma. I can imagine one, but we and others around the world have been looking for biomarkers in kidney cancer for, I mean, I've been saying the same thing probably for 20 years now. Do we still have anything now today that's usable in clinic for patient selection for treatment? No, we don't. Will we have something? Yes, I think so, but it's a complicated disease, kidney cancer. It doesn't really have driver mutations. It's dominated by tumour suppressor genes, so there's various issues there. And certainly from our work in the last 10 or 15 years, there's a big problem with intratumour heterogeneity. In other words, if you take out a nephrectomy or do a biopsy preoperatively of a large kidney cancer tumour, how do you actually know that the bit of the tumour that you biopsy is going to be representative of potential drivers of metastatic disease? So there's a lot of difficult issues in there, I think, which is probably one of the reasons we don't have usable biomarkers at the moment, despite a lot of effort. I mean, again, treating melanoma and kidney cancer, we know that nivolumab and ipilimumab in melanoma, metastatic melanoma, probably leads to cure, if I might say that, in about 50% of patients in the clinic. We use ipi/nivo in renal cancer as well, and I truly think, and I think the data show this now, we've got long follow-up from the original ipi/nivo trial, that in kidney cancer you probably have the possibility of long-term disease control or cure of about 30%, so lower than melanoma. So what that says to me is that if you could potentially use ipi/nivo, for example, in a neoadjuvant setting, assuming that the toxicity can be managed appropriately, and per label we use a lower dose of ipi in kidney cancer than in melanoma, and you can mitigate the risk of disease progression, because that's obviously important with neoadjuvant as well, to make sure that you're not having a situation where the non-responders become irresectable. So I think that's really important for clinical trial design. I think with that type of strategy, accepting that in general people with kidney cancer are a little bit older and less fit than people with melanoma, I think in appropriately selected patients, I can actually see in the future that there's a neoadjuvant treatment that's successful. And I can just bookend that with one comment which might be relevant, that quite commonly, not commonly, but maybe 15% of people with kidney cancer will present with metastatic disease with the primary in situ. And often those patients, we will treat them with ipi/nivo, and they'll respond really, really well at the metastatic sites. And then what we'll do is what people call a delayed cytoreductive nephrectomy to take out the primary tumour mass. So there are some precedents, I guess is the point I'm making, in metastatic disease that you could see how you might be able to extrapolate into a neoadjuvant setting. Bound to be, which is a really, really important question, I think, as well. And maybe, I don't know if this gets enough airtime, is how long should you give neoadjuvant treatment for And I mean, there's a letter in NEJM actually earlier this year from the Memorial Group, and this was in colorectal cancer with checkpoint inhibitors, MMR deficient. And I don't know if you saw this or not, but there's a really nice graph where the longer you give the neoadjuvant treatment for, the higher chance of pathological response. So I wonder if one of the issues that's in here is that the attempts so far in kidney cancer to give neoadjuvant treatment with checkpoint inhibitors often haven't been for long periods of time. And then I wonder if we should be actually thinking about giving treatment 3-6 months even, again with appropriate safeguards in terms of non-responding patients. So I think there's still lots and lots of questions to answer actually, but I'm optimistic overall.